Lovely.
Go over to the display settings again.
Swap screens. Gosh, too many screens, too many screens. Okay, fine. So, yeah, welcome. As Judith said, I'm an emergency nurse practitioner, and I currently work as an ENP in the minor injuries unit in Neath Port Talbot in South Wales. I've been doing this role for about 5 years in total now, but 2 years fully qualified, and have a keen interest in eyes especially. So I thought I would just like to throw out this free educational webinar as part of some developing a knowledge for new emergency nurses, staff nurses, and maybe some CPD for ENP. So just going to start sharing my next slide. Can you see the top of the screen that says mute stop video? Or is that just on mine, guys?
Just on yours, I think.
Oh,
yeah.
Okay, because it looks like it's in the way. So just a bit of webinar etiquette. Just to let you all know that the session is being recorded because we like to make them available for catch-up to other members of the faculty. We're quite a small group, so I'm happy for you to have your cameras on and mute if you'd like, if you want to ask any questions. If the group becomes any larger, then we'll just keep our record microphones and videos on mute because it can cause an interference with the signal. If you find that the signal and reception is, then try turning your camera off if you've got it on. And otherwise, if you do want to speak, just use the chat function and you'll come off mute quite quickly. Any questions I will try and answer throughout the webinar, or if you don't have any and think of something afterwards, just send me an email or a message. And just to let you know, you can, if you fill in the feedback form, when the webinar is uploaded to the website, then you will be sent out a certificate of attendance for CPD. I think it covers about 2 hours of CPD. Okay, so hope you enjoy, and like I said, bear with me. It's my first time presenting, so I'm a little bit nervous. So this session, I'm going to cover chemical eye injuries, and we will discuss some anatomy and physiology of the eye and look at the process really from triage, initial presentation, and then through to irrigation and post-irrigation assessment, and the importance of chemical eye injuries in the ED. Just move this over there. Lovely. So just a note as well that I've tried to aim this at all levels of emergency nurses, from the triage staff nurses and through to the EMPs and maybe some advanced practitioners. So I've tried to aim it at everybody, but not every aspect of this is going to be in your job role. So just beware of that. It's not an educational webinar where you can go off and do something if you're not deemed competent. So just remember to work within your scope of practice. So I've talked a bit about who I am. Skip on. So what is a chemical burn to the eye? In a nutshell, exposure of the eye to any chemical agent, accidental or intentional, with potential blinding resulting. They account for 11 to 22% of all ocular trauma and occur primarily in industrial or agricultural work settings. We also see them quite often now with home cleaners and in association with criminal assault once or twice in the minor injuries unit. The typical presentation age is between 20 to 40-year-olds, and we typically see men in the minor injuries unit where I work, and mainly because of their occupational hazard. So the most common chemical burns that we tend to see in the minor injuries or in the ED departments are typically plaster in the eye, wet plaster or wet cement in the eye, inadvertent handling of chemicals, cleaning products, industrial fluids, and we actually see some kids come in with sprayed perfume in the eye as well. I'm pretty sure you've all seen that if you work in the ED, or they've got hold of something and got it in the eye. Some more rarer chemical burns that I've yet to see. I haven't seen an exploding battery, but it's on the list of chemical burn to the eye, and airbag deployment in cars and intentional assaults. I'm not sure if anybody has seen any acid attacks in their ED, but they do happen. They're out there, probably in the bigger cities as opposed to rural Wales. I'm sorry, let's go now. Go on. To the dog so you can't hear the tippy tapping. Just let me know if anybody has a question, because I can't see any screen other than mine. So any problems, just let me know, or send a message to the chat. Otherwise, okay. So I briefly talked about a chemical in the eye, and now we're going to get on to the anatomy of the eye. This may be a little bit in depth for some of you, or it may well be quite basic. So we'll start with the actual eyeball itself. It's made up of 3 layers: the inner layer, the fibrous layer, and the outer layer. And the fibrous layer is the very outer layer, and this is comprised of the white part of the eye, the cornea, which provides shape and support to the deeper structures. I'm sure you all know what the sclera is, the white part of the eye. It's continuous with the cornea and forms the external protective coat of the eye. It also protects the muscle attachments for the intraocular muscles and is made up of quite a thick fibrous material. The cornea, as you all know, is the circular, transparent part positioned very centrally at the front. It's designed to refract light entering the eye onto the lens, which then focuses onto the retina. And the cornea contains no blood vessels, and it's very sensitive to pain. So I'm sure you've all seen the typical foreign body or chemical burn patient come in. They have severe pain to the front of the eye. Looking at the cornea, because the cornea tends to be where we see most of the injuries and the most of the defects in the chemical injury or any injury to the eye. You'll hear people talking about a corneal abrasion or a corneal foreign body. And that's relevant in my practice, because when we're assessing the severity, then we tend to need to know the layers of the cornea, not to a great extent, but just so we know the epithelium tends to be the very outer surface, as you can see here. It's a layer of cells. Its main function is to provide a barrier from infection and dust. It has rapid cell degeneration and typically tends to heal quite quickly within 24 to 48 hours. And the cells regenerate within 3 to 5 days, which is sped up mainly more so with a wound or an abrasion. So I tend to advise the patients as well, when we see these abrasions, that they heal really quite quickly. Might be uncomfortable for a few days, but they should be symptom-free within a few days typically. The next layer underneath then is the Bowman's layer. This is a tough basement membrane, highly resistant to penetration or damage, but it doesn't regenerate if it is injured, and it actually can result in stromal scar tissue, which tends to be the haziness that you would see in a corneal scar or somebody's had previous injury. The connective stroma tissue then underneath here, so this is quite a thick layer of collagen fibers, makes up the majority of the cornea and is responsible for the clarity and integrity of light being projected through into the eye. And again, so injuries at this level can scar quite significantly. If they've had an injury down to the stroma here, then you'll quite often see that haziness that comes with severe injuries, and the prognosis for these are pretty poor. The third layer then underneath, the fourth layer underneath is Decimate's layer. So this is the inner layer basement membrane of endothelium, and highly resistant to trauma, but again, cells can regenerate. Not sure how effective this is, because if you've got an injury that is down to this level, then you're in trouble anyway. But sorry, I've just had a notification on the screen. Apologies. It forms the inner barrier to spread of infection and the health of the endothelium cells, the very inner layer. So the very base layer inside the eye, then, which is pretty much just between the cornea and the anterior chamber, is the endothelium. This separates the anterior chamber from the rest of the eye, and it regulates the fluid leakage with aqueous humor. So it just sort of lets a little bit of fluid through, enough to keep the eye nice and moist, but at the same time, injuries at this level cause high risk to penetration of the eye, and prognosis is not good with any injuries here. And this is where you'll also see it's pretty much behind this level of endothelium that you'll see the anterior chamber. When we talk about looking at the anterior chamber for blood or hypopyon, which is pus in the anterior chamber, it is pretty much sitting on this side between the anterior chamber and the base. So made up of 5 layers here. I tend to, in the minor injuries unit, I've only ever seen injury as far as the stroma, where they've had stromal haze. I have yet to see somebody with a nasty penetrating eye injury or a significant burn, which is a full thickness burn. Okay, so the vascular layer, which is the layer outside of the outer layer. So this is made up of the iris and the pupil, the choroid and the ciliary body. So I'm sure you all know what the iris is and the pupil. The iris is the colored part of the eye here, the circular structure, and is actually made up of smooth muscle fibers with the aperture in the middle, which is the pupil. A lot of people think it's the pupil that decreases and contracts and increases in size, but it's actually the ciliary muscle and the muscle fibers within the iris, innervated by the autonomic system, which regulate the amount of light that enters the eye through the pupil. So this constricts and dilates, and that's when you see the change in pupil dilation. The circular opening of the pupil in the center of the iris, as we all know as the pupils. I'm pretty sure everybody that's in the room at the moment or anybody watching has an awareness of the pupil reaction and the pupil response when it changes to light. And the smooth muscle fibers of the iris constrict and relax, and like I said, alter the diameter of the pupil. The choroid is the middle layer of connective tissue and blood vessels, which sits between the retina and the sclera. So I'm going to share the next slide actually, because I've got a picture here which may well help you picture some of this. So even though this is the inner layer, we'll I can't see the previous one. That's frustrating. Okay. So yeah, the choroid, middle layer of connective tissue and blood vessels. It nourishes the outer layer of the retina and contains the pigment that absorbs excess light, preventing blurred vision. And the ciliary body, the choroid and the ciliary body are pretty much one and the same. So it's made up of 2 parts, the ciliary muscle and smooth muscle fibers, which attach to the lens, which again contract and dilate, altering the size of the lens. And together they work as the ciliary body, controlling the shape of the lens. So I could have done with putting a picture on the previous one. I've just realized that, guys. So yeah, just to put it maybe a bit more simply, here we've got the cornea with the 5 layers that we've just explained. The iris here, which is the colored part of muscle fibers, which contract and dilate to change the amount of light that enters through the pupil here, and then the amount of light that's refracted onto the lens. So this is our lens here, just sitting, and the ciliary body on either side here. So these muscle fibers contract, altering the size of the lens here. And so the choroid layer, which we have here, is pretty much the very inner layer that combines the ciliary body and around to the choroid around here. Okay. It took me a while to get my head around all of this, so I'm sure I'm frying your brains right now. But I've got a pretty quick video which puts it all into context and the physiology of the eye, makes it a little bit easier to understand. So the inner layer is made up of all of these, the sort of posterior eye that we talk about, or inside the eye. The retina, which is this light sensitive part of the eye here at the posterior here. So this is light sensitive layer that lines the interior of the eye and is mainly composed of the light sensitive cells known as rods and cones. The eye contains about 125 million rod cells, which are necessary for seeing in the dim light. And there are between 6 and 7 million cone cells in the eye. So I found that quite interesting, the amount of cells that we have here. The cone cells are essential for receiving the sharp, accurate image and for distinguishing colors and best function in bright light. So between the two, it allows our vision to be pretty sharp and accurate. The macula, which is in the center of the retina, which I think is, this? Oh, it's not on my picture, that's useful. So the macula is the center of the retina and is marked by the yellow spot. And it, obviously we've all heard of macular degeneration. It's highly pigmented and contains depression called the fovea. So yeah, I thought this was the macula here, right at the very back here. And the fovea further sits within the around the macula here, and this is has the greatest concentration of cone cells here. And when the eye is directed at a specific object, this is the part of the image that is focused on the fovea. So the light refracts through the lens and is directed onto this aspect here. And it is the part where the brain nerves here then tell the brain what we're seeing. The optic disc identifies the start of the optic nerves, and this is where the messages are then sent to the brain that are received by the cone cells and the rod cells, leave the optic nerve here to the center of the brain. See if I've missed anything. So, and this is also where the blind spot is. So we actually can't visualize anything when it's refracting. And when we look at this spot here, we all have a blind spot, and it contains no light detecting cells. They stop here and here. The optic nerves, I'm not going to go into those too much, but they obviously transfer all of this visual information from the cells to the brain. Brain fried yet? Okay. So some other structures of the eyeball that sit within it. We've got the vitreous body. The vitreous body is a transparent gel which fills the posterior segment of the eyeball in here and is responsible for the magnifying power that comes through the lens and that's focused onto the fovea. And it also helps to support the eyeball in its shape as well. The anterior segment, let's have a look, am I on the, yeah, anterior and posterior chambers. I'm sure you've all heard of these. So as an ENP or practitioner, we check the anterior chamber on examination, and the anterior is located between the cornea and the iris, which is this part here, and the posterior chamber, I believe it's hard to describe on this this slide here, but is pretty much just between the iris and the ciliary body. So but this part here is the posterior chamber. The chambers are filled with aqueous fluid as opposed to vitreous humor. And the aqueous humor is produced constantly draining through a trabecular meshwork, which sits at the bottom of the cornea here. Oh, we don't have that on the picture, but it's a trabecular meshwork, which is an area of tissue at the base of the cornea, sitting in the anterior chamber. The conjunctiva, yeah, last but not least, so the conjunctiva is a clear thin membrane that covers the front surface part of the eye. And again, I'm sure you've all heard of the conjunctiva. If you're an assessing practitioner, we assess the conjunctiva and assess for signs of conjunctivitis and injection of the conjunctiva. It's actually called the bulbar conjunctiva, what we look at when we see the white part with a conjunctiva laying over it. And the inner surface of the upper and lower eyelids, where the conjunctiva folds back onto, is the palpebral conjunctiva. So I don't tend to document whether I'm looking at the bulbar or palpebral, but it's good to know because it's one continuous membrane that doubles back and envelopes under the eyelids. It helps to keep the eye and the inner eyelids moist and lubricated. Hence conjunctivitis. When it gets inflamed, the eye gets a bit dry and a bit gritty, and what they're feeling is the dry inner surface of the eyelids. Other structures of the eye then. So the extraocular muscles, we assess these as well during practice, and there are 6 muscles attached to the sclera, 4 rectus muscles and 2 oblique. So I've got a nice picture here because I'm a big fan of pictures and I tend to understand things more when I see them in pictures or videos. So the 4 rectus muscles and 2 oblique. The muscles all originate from a common tendinous ring posterior to the eye, which surrounds the optic canal at the back of the orbit. Each one of them has a different interaction with regards to range of movement of the eyeball. The levator palpebrae, I can't pronounce this, levator palpebrae superioris, LPS, is the main muscle involved for raising the upper eyelid, which is attached to the tarsal plate. And we tend to test this muscle when we're testing the cranial nerve, and we get the patient to resist eye opening to check the power of it. It attaches in the upper eyelid anteriorly, and it's quite a strong, thick part of attachment of the muscle is where we evert the eyelid, and you can almost feel the strength of it when you're flipping the eyelid inside out. But it's just one muscle, innervated by the cranial nerve, 3rd cranial nerve, I believe. Yeah, 3rd cranial nerve, and other nerves that innervate then. So I actually found this quite interesting when I was writing, gathering evidence for the presentation, was this little acronym here to remember which nerves, which cranial nerves innervate the movement of the eye. So we've got LR6, which is the lateral rectus, which is cranial nerve 6, and the SO, which is superior oblique 4, and then the recti muscles, which is the 3rd cranial nerve. So LR6, SO4, R3. And you can see here, so your 3rd one is the oculomotor nerve, which we test, the trochlear nerve, and the abducens. I'm going to be honest, when I'm assessing, I don't know the names of them, which is why I found that quite useful, because it may well stick with me a bit more in future. But as we'll talk about later, I just tend to assess the range of movement. And if I find a problem with the range of movement, that's when I tend to look it up and find out which nerve may well be affected or which muscle might be affected. So, pictures. So, just to sum it all up, we've got this iris here on the center, the limbus, which actually I didn't mention the limbus. So the limbus is where the cornea meets the sclera here all around the circular outer part of the cornea. It meets the sclera, which is the white part of the eye, and the conjunctiva, which you can't see properly unless you're really looking underneath a slit lamp. On close inspection, you can actually see that it's a membrane with a clear film with some fluid underneath. The pupil, as you see here, lets the light in through and refracts onto the lens. So, ciliary processes, vitreous body filled with lots of anatomy parts. And I'm going to sum it up by just showing you, because it's very difficult to explain the physiology of the eye. And after taking in a lot of this anatomy, I found a good video that can explain the physiology and put some of this anatomy into perspective and what it means for testing visual acuity and assessment of the eye, and how it can be affected. So I'm just going to see if this works, and hopefully it'll share my.
I looked into it because I like my second hand.
My sound as well.
For amazing views.
So if I move that across
there,
there,
something which already has a story to it, instead of.
If I pause, can somebody tell me? Can you hear the sound of the video, guys?
Yeah.
Yeah.
Is it loud and clear?
Need to play it again, Susan.
Ah, lovely.
We can see tiny specks and huge mountains. We can see in the dark.
Yeah, it's okay.
We can see hundreds of shades of bright, vibrant colours.
It's fine. It's loud enough.
Yeah, can you see it and hear it?
Yeah.
Oh, lovely. It's only a few minutes long.
How does the eye work? The eye contains special cells that receive the incoming light energy and convert it into electrical impulses. These electrical impulses are then relayed along the optic nerve to our brain. So let's have a look at the special parts of the eye that enable us to see. The cornea covers the entire front part of the eye. It is convex shaped, and so it bends or refracts incoming light into the lens. The lens is a transparent, biconvex, flexible structure that focuses light into the retina. If we want to see something close, the lens is made to be thicker, and when we want to see something further away, the lens is made to be thinner. These changes increase or decrease the refraction of incoming light onto the retina. Changing the thickness and curvature of the lens is done by the ciliary muscle contracting and relaxing, which are connected to the lens by suspensory ligaments. The iris is the colored part of the eye. It is the muscular structure that regulates the size of the pupil, the black opening in the middle of our eyes that controls the amount of light that enters the eye. The iris does this by expanding or contracting, depending upon the amount of light present in our surroundings. When there is a lot of light, the iris expands, so the pupil becomes smaller, and so less light will enter. When there is less light, the iris contracts, making the pupil larger, so more light can enter. The color of our iris depends on how much protein, called melanin, is present, and is determined by our genetics. Brown-eyed individuals have more melanin, whereas blue-eyed individuals have less. So light enters the eye through the cornea and passes through the pupil onto the lens. The lens refracts light through the vitreous humor to the retina. The retina at the back of the eye contains a thin lining of special cells called photoreceptor cells. There are two types of photoreceptor cells, the rod cells and the cone cells. They have distinctive shapes and are sensitive to different kinds of light. We have approximately 120 million rod cells, which allow us to see black, white, and shades of grey. The rods enable us to determine the shape of objects. As rods are sensitive to reduced light, they provide us with night vision, and so nocturnal animals have lots of rods. Our 7 million cone cells specifically allow us to see color. Although these cells can only differentiate between red, green, and blue, they all work together so we can see hundreds of different shades of color. In general, the more cones per unit area of the retina, the finer the detail that can be seen. Where the optic nerve connects to the eye, there are no rod or cone cells. This is known as the blind spot. When light enters the eye, it passes through the cornea, through the pupil, and refracts through the lens, across the vitreous humor, and focuses an image onto the retina. Light-sensitive rods and cones react to specific wavelengths of light and trigger nerve impulses. These impulses are carried through the optic nerve to the visual centers of the brain, where the impulses are organized and interpreted to give us sight as we know it. So there we have the different parts of the eye and how they work together to give us sight. Give these questions a go to test your knowledge. Did you get them right?
If you like the video, give it a thumbs up and don't forget to subscribe. Comment below if you have any questions.
So, quick little video just to put it all into perspective. It's quite difficult to get your head all around it. If you're anything like me, there's lots going on, but I found that very fascinating. Just learning a bit more about the deeper anatomy of the eye and how it all works. This is all relevant for me because I see chemical eye injuries quite often, as well as foreign bodies. They tend to be the most typical presentation for eye injuries. And in the minor injuries unit, they are sounds awful, but they're one of my favorite things because they just fascinate me. But I've got a passion for chemical eye injuries because I've just how important they are. And I just like to make sure that the patients get the most appropriate, timely treatment that they should have. A couple of reasons for that is the basis that I wanted to do this presentation is because we recently had a patient attend the minor injuries unit. I just wanted to share with you just so that maybe you could think about this when we're talking about the example that I'm going to put up now shortly. In fact, let's stick it up. So we actually had a 49-year-old gentleman who presented first thing in the morning to the minor injuries unit with a very painful red eye. And at triage, he claimed that something in work had gone into his eye and it was still painful and he had some blurred vision. He then proceeded to tell us that he'd been to the local ED the night before and they had triaged him, and he said that he'd waited some good few hours to be seen, and then when he inquired about how much longer he would be, he was told that it was going to be at least another 6 to 8 hours and that he should probably attend the minor injuries unit in Eastport Talbot first thing in the morning when we opened. So a couple of problems with that is more so in the essence that there is no way on earth this gentleman should have been waiting longer than 10 minutes to be seen with his chemical eye injury. Even though he stated on triage that it was something at work that splashed into his eye, listening to the history in a bit more depth, it was quite clear that he was a plasterer and that he was plastering a ceiling and inadvertently got some wet plaster in his eye. Now, if you don't know anything much about chemical eye injuries, and that's why I felt like it would be important, or maybe I'd just like to share some more information and education about the importance of chemical eye injuries, is that the alkali present in wet plaster can be sight threatening and it can cause severe pain and damage within a short amount of time. So I'm not naysaying about anybody in particular or about this ED. I just think maybe lack of education meant that he was actually triaged inappropriately when he first presented. And he was actually triaged as a P3, I think, which was a green, and so therefore was in the 4-hour waiting. When I had a little look at the triage history on Welsh Pass, I was able to see that it was actually documented that he had some blurred vision and pain from something going in his eye. So, but no visual acuity was also assessed. So it was just a pretty poor triage, really. And I just think it's important that we all know a bit more about the importance of chemical eye injuries. So, so let's just think about that. I'm not sure how many of you are practitioners or how many of you are triage nurses or staff nurses wanting to go into triage. So just wanted you to have a think about this. It's a very similar presentation. 49-year-old man presents to triage in your ED. He says something has splashed in his eye at work and it is painful and he has some blurred vision. So how would you proceed to triage him? What more would you ask him at the time, initially on presentation? What would your next actions be? So I think I put in a coffee break here, or at least 5 minutes to go make a coffee so that you're not all falling asleep as I ramble. While you go make a coffee, just think about what you would do in respect with triage. If any of you are happy, I'm happy for you to comment and either message into the chat would be great. Or if you want to come off mute, then that's great. If you want to interact a little bit, we're quite a smallish group now, I can see. It doesn't look like there are, beg your pardon, doesn't look like there are many here. So have a think about it. Would you triage and place him back in the waiting room to be seen, or, as in my patient's case, redirect him from the A&E to a minor injury unit? Any ideas on how you triage? So I'm just going to pause it here for a minute, guys. Go and get a break, go and get a coffee. And what time is it? So it's just gone 5:02. So we'll just have a few minutes because I'm aware that because of the technical glitch, we started a bit late. So we'll just have 5 minutes, and then if you want to drink your coffee or eat a snack, then you can do that. Okay.
Okay.
Perfect, thank you. Yep.
It's very quiet. Yeah, to let me know because I can't see anybody. I can't even see myself. So
No problem.
I'm gonna pause share. No, stop share. Okay, are you all back?
Yeah.
I can see people on the screen now on this one.
Yeah.
Lovely. So I think I've swapped my screens over so that I'm not looking away from the camera when I'm reading some of my notes that I've got here. The screen that I'm sharing, oh, Sandra, lovely. This screen that I'm sharing, is that the full page with Manchester Triage, or are you looking at my notes as well?
No, just my triage.
Lovely.
Yeah.
Okay, so let's press on. So yeah, so I would expect to see the typical acute chemical eye injury booked in triage and assessed in triage. A chemical eye injury is always going to be a red, a P1 for immediate assessment. So how on earth my gentleman that got redirected from the ED to the minor injuries was triaged as a green P3, I believe, with a 4-hour wait. I don't know, because any substance splashed into or placed into the eye, let's have a look. Any substance splashed into or placed in the eye that causes a stinging, burning or reduced vision should be assumed to have caused a chemical injury. Doesn't matter what the chemical is, until you are certain what it is, you triage them as an acute chemical eye injury according to the Manchester Triage, which will always come out as a red. I know this may not always seem feasible that they get immediate treatment, but it's very important that they do. As you can see from the picture here, this is somebody who has sustained a chemical burn to the eye and with some significant scleral ischemia and hazing of the cornea. Covered that. So how would you have triaged this patient? Anybody want to give some insight onto what we could do? In just a few brief words, rapidly. Triage rapidly.
When it happened, how it happened, and what happened, what's gone in the eye.
Yeah, so I've already put it up on the screen, but yeah, brilliant. What on triage? It's a chemical injury to the eye. Let me shut the door so the dogs don't bother us. Sorry. Yeah, so the main thing we want to know is what chemical has gone in the eye, the time since the chemical exposure, any first aid treatment performed by the patient, and ideally what are their symptoms on triage, and any relevant ocular or medical history would be useful to know. So are they wearing contact lenses? If so, get them out. Ideally on triage, I would like to, if the triage nurse is competent, and you'll see from this presentation, if you're watching it on catch up, that we go through testing the pH. It might seem very basic to some nurse practitioners or assessing practitioners or experienced emergency nurses that are already doing it. But when I started out in A&E, I didn't actually have anybody really that showed me or explained testing the pH. And it's one of the priority things you want to do, short of determining what the chemical is and how long it's been in there and getting some first aid irrigation. I've actually read evidence recently, and in practice in the past, I have actually put tetracaine in, or the triage nurses have put tetracaine in because of the pain when the patient presents. Evidence suggests that it's best to check the pH before giving the tetracaine, as it can slightly alter the pH. So what I tend to advise the triage nurses in our department is to rapidly ask the questions: what chemical has gone in the eye, how long has it happened, and actually try and obviously if they've seen it on the computer, on the Welsh pads, and they know what the patient's presenting with, I tend to advise them to get the pH paper and test the pH while they're checking some of these questions, because it just results in a nice rapid triage, and a pH can be ascertained, and then tetracaine or any other analgesia can be given as soon as possible. They're very painful chemical injuries to the eye, anything in the eye, foreign bodies, but chemical, I'm not sure if anybody's had a nasty chemical, but very painful. The cornea is very sensitive. So get the pH done while you're checking all of these questions on triage. Make sure you've assessed them as a red, acute chemical eye injury on the Manchester triage. And I've got to be honest, and I'm quite lucky in our minor injuries unit, because if there's a chemical eye injury, I tend to prioritize them, and I quite often will ask the HCA, who's our healthcare assistants, are competent in testing the pH. So I tend to get them to bring the patient through, and I will either see and treat, or if I'm unable to do that, the triage nurse will get a quick triage and then ask the healthcare assistant to test the pH. And it's pretty much done within the space of 10 minutes. We're pretty good. We don't have any chemical eye injuries waiting long, even if it is something like perfume or a dilute shampoo or household cleaner tends to be quite common. Plaster we tend to see most of, or like I said, in the occupational hazards with men. But no matter what it is, pH is what's going to determine your management and the irrigation. So
could I just ask about when you're checking the pH?
Yeah.
Because we always seem to have a conflicting of how long you read how long after you read the litmus paper, or how long you can read it for, because it changes, doesn't it, sometimes, the longer you leave it. So should you read it immediately, or should you wait a little while?
So when I was gathering, I quite often will test the pH, and I'm in the practice really because we tend to give the pH, give the tetracaine after we've tested the pH. I tend to test the pH and then go and get the tetracaine and then come back. And by the time that has set, it's typically about half a minute to a minute. And I found that then in evidence-based, when I was researching to put together the presentation, it was actually in the one of the emergency nursing articles that 30 seconds is recommended to leave it to get an accurate pH.
And how long do you leave 20 minutes after irrigation before you check the pH again, or?
Oh yeah.
How long are you trying to,
Yeah. So we'll cover that now. About 5 to 8 slides, but yeah. So from triage, that's all I would expect the triage nurse to do if they're competent is the pH and get some of this. But yeah, once you've actually irrigated, so we test the baseline pH when the patient comes in, one of the first things. We tend to read it 30 seconds to a minute or so afterwards. I'm in the habit, like I said, of going and getting the pain relief or clarifying a few details, or even getting the irrigation equipment set up, and then double check the pH then at 30 seconds to a minute afterwards. But yeah, after the irrigation, you want to be leaving it about 15 to 20 minutes. I think that was recommended as well.
Thank you.
Yeah, so triage history, for those of you that are maybe emergency staff nurses watching that are here or on catch-up, this is typically what I would expect to see, or the sort of details that I would have obtained on triage as a triage, or how I tend to document it if I'm seeing and treating. Mine is probably a little bit more detailed than what it has here, but we go on to talk about the assessing practitioners history taken in a little while. So for triage nurses, you want to just clearly state this is an acute chemical eye injury. I tend to document the patient's age and a nice sort of brief history of what happened. So for instance, as an example, our gentleman that we talked about that walked in, he's a 49-year-old male. Time since exposure we've got here, so I would pretty much document it as patient states he's a plasterer while at work skimming a client's ceiling, wet gypsum plaster. So this is the type of chemical that would have been entered into the eye. How long ago? So it was his left eye 1 hour ago. He self-irrigated for 40 to 60 minutes and hadn't taken analgesia. So I tend to put that, or at least advise the triage nurses to document or find out if they've taken oral analgesia, because it can also help with some pain afterwards. So even though we can give tetracaine, which is a quick fast acting, the tetracaine only tends to last for about 20 minutes. And after the Morgan lens irrigation, after the assessment and on discharge, they're going to be feeling a pretty throbbing eye. It's not going to be comfortable. So I tend to give them paracetamol as well at triage, or at least give them some before irrigation. Basic symptoms, or the symptoms that the triage nurse can ask for, obviously pain, and it's evidence suggests or recommends trying to document or ascertain what type of pain. Is it a sharp pain, aching pain, gritty or burning? Do they have any blurred vision, double vision, or visual loss that they're aware of? Has the eye been watering? And do they have any photophobia? So that's a sensitivity to bright light. And triage that I tend to see them will be written as above, and then patient complaining of a sharp pain with blurred vision, eye watering, no photophobia. These aren't necessary, if I'm honest, for the triage nurse to document. The priority is getting the pH and getting them through for the assessing practitioner. Obviously, before they were to give any tetracaine, if they did, after checking the pH, they would need to check the allergies. So be sure to check the allergies and any past medical history, drug history, or tetanus status, if time allows, at triage. So it's not always possible. If they're in a lot of pain, you don't want to be you know, going through their past medical history, but some of that will be relevant for the assessing practitioner, such as myself, for instance. If somebody has cataracts or previous surgery, we'll explain a bit later on about the importance, because that can cause some complications when you're assessing the cornea. It's actually important so that the triage nurse as well. So if you're triaging the patient, good to ask them if they've got contact lenses in and remove them if they have, before or after testing the pH. Ideally, you just want to know what's in the eye, how long ago it was the exposure, have they self-irrigated, what symptoms have they got, and if they've got contact lenses in, remove them. So here's a bit of a how-to on testing the pH for those of you not familiar. Like I said, I was never really given guidance on how. It was a see one, do one, and look at the paper and check the colours, really. There isn't really an awful lot more to it than that. However, if you are a healthcare assistant or a triage nurse and this is really new to you, then I figured this might well help. You can also use this. I know that we do have some, on the FEN website, there's some demonstration of practical skills. So those will be available. And I did think about those, because if in practice you want to be assessed as competent for doing this, if it's in your scope and your department allows, then get somebody to observe you doing this and get a DOPS for it, and that'll be good for your portfolio. It's something that I never got a DOPS for, but we're assessing now competence of the healthcare assistants and some of the triage nurses on some of the skills that they've been doing, just to show their demonstration of competence in those things. And testing pH, insertion of Morgan lens is one of them. So use those forms when they're on the website. I'm not sure if they're up there just yet, but they will be imminently in the future. So I'll just go through this for those of you that may not be familiar with it. Obviously, you want to reassure the patient, check for any allergies, and just obtain informed consent. If you're not familiar with litmus paper, it should be available in your department. And it's typically comes in a yellow roll with the colour indicator on the top of the lid there. Whilst researching for this presentation and putting together, I did learn that you can actually use urinalysis strips if there's no pH paper, which I didn't know. That was new to me. Of course, the center aspect of the urinalysis is a pH, very small, but a pH, pardon me. And so failing that, you can actually bend the urinalysis strip and use that, but we tend to freely have pH paper available in our unit, sorry. And so, yeah, 2 strips of paper. I always tear off 2 because I always check both eyes, even if one of them is only affected. You want to compare as a baseline, really. Sometimes if one eye is affected only and you check the both, and both eyes are of the same pH, then you know that you haven't got too much to worry about with the sense of, is it an acid or is it an alkali? However, if the patient is symptomatic, no matter what the chemical, evidence advises that you just start irrigation no matter what, to help comfort the patient and wash anything out. So 2 strips of paper, and fold down the end of the litmus paper and just pop it in. So actually putting it into the outer aspect of the eye and into the lower lid fornix is where you want to go. So that's the space in between the lower eyelid and the white part. You'll see that as soon as you touch it, hopefully if they've got some nice tear fluid there, you'll see that the paper changes color pretty much straight away. What I do see quite a bit of in practice, and I tend to nag them quite a bit, is this very, very small amount of fluid on the pH paper, barely enough to get a good reading. So I tend to hold it in the patient's eye as long as they can tolerate, so maybe 20 to 30 seconds, and observe for a good color change and watch the fluid absorb up the paper. And I tend to like to see a good sort of 0.5 centimeters really. And that way you can, you know, accurately sort of compare then, rather than a tiny little splodge of color. It's very difficult to get a good pH from that. So if you're finding the patient's eye is quite dry, I tend to just move slightly inwards to where the tear film is a bit more there's a bit more lubricant of the tear film. Just be careful not to scratch the cornea. It's actually quite a painful procedure. I did it on myself once when I was testing the pH accuracy, and it actually feels quite sharp when it goes in. So just be careful when you're doing it, and obviously just reassure the patient that it's important to be doing it. The emergency nursing that I took this from article did say 30 seconds was best to compare the color against the indicator. So that probably marries up with what I tend to do. So I test the pH and leave it set for a minute or so. In the meantime, I explain to the patient that I'm going to get them some tetracaine, some pain relief to put in the eye to make it numb. So actually I did tend to give the analgesia before. It was only when I did my my training as an emergency nurse practitioner and I wrote my case studies that I read evidence that suggests taking the pH before. Prior to that, when I was a triage nurse and working in the ED, we would just put tetracaine in straight away to give the patient some good analgesia and relief from the pain. But yeah, since doing my training, I read that it can actually affect some of the pH of the chemicals and not give a true pH. So I tend to sort of recommend now that we either get a pH straight away in triage prior to the triage nurse giving analgesia, which tends to be recommended, but it's not always possible in triage. I know that triage is quite often backed up with things, but like I said earlier, it's quite straightforward to ask those questions while you're testing the pH. Just sort of communicate with the patient that you're doing that so that you can give them analgesia, because it's very important. What we tend to give in our minor injuries unit, and I think what's quite widely used, is tetracaine and oxybuprocaine, which I don't use very often, but in the last 6 months, I learned that we can give this to children. It's preferred in young children because it actually stings less. I've got to be honest, I still give tetracaine. It tends to be the most commonly used anesthetic topically. And obviously checking for allergies before you give it. And for those of you not able to give on PGD or non-prescribers, make sure that this is prescribed by a practitioner who can prescribe, or that you're given it as a PGD and that you are qualified and that you have read the PGD and you're fully aware of the limits of what you can give. Tetracaine and oxybuprocaine are on PGD in our minor injuries. So even though I'm not a prescriber, I can give tetracaine on PGD. And I read the oxybuprocaine a couple of months ago when I realized that we stopped that. And I read that it was, I said, preferable to use in children purely because it stings less. But I've got to be honest, if the child is screaming because of the chemical in the eye, which tends to be the case, put in the tetracaine in within 2 minutes, gives them good relief. And normally they're screaming because of the pain. And as soon as you get that tetracaine in, even though it can sting, within a couple of minutes, they're happy. Or in some cases, even sleeping in mum's arms. If you're not aware, it's 1 to 2 drops into the eyes, and we tend to put it into the whole, to hold the lower eyelid down and put it into the lower fornix. Again, I did read a difference in evidence when I was gathering information for the presentation that seemed to be conflicting about whether it went to the inner aspect or the outer aspect. So I tend to just get it in there. I'm not fussy, if I'm honest. I think it's to do with the drainage of the tear film, and it's a bit less effective if you put it on the inner aspect because it's more likely to drain away. But all the patients I tend to put it in get good effect. I thought it might be interesting to know, because I actually found when I was training to be a nurse practitioner, that Tetra can be used in all ages except for neonates. So children, you know, of any age, we don't see neonates in our minor injuries, and I don't know if any of you are peds nurses. I don't think we've actually ever had a really young, only sort of toddler age or infants more so, that have had to have tetracaine with chemical injuries. I suppose they're just more perfume sprays or something, if they've picked up mum's perfume and accidentally got it in their eyes. But yeah, it can be used in all ages except for neonates. A couple of the EMPs in our department didn't know that until recently, because they thought that because it was a local topical anesthetic and stung quite a lot, that maybe it couldn't. But yeah, check that out, and definitely if they're in pain, anesthetize it. It only lasts for about 15 to 20 minutes. So it only lasts for about 15 to 20 minutes. So, but it can be given repeatedly in between irrigations. I think I remember reading at 5-minute intervals. So you can give 2 drops, and then 5-10 minutes later, you can give another 2 drops. However, the patient never really needs that. I tend to give it an initial presentation prior to Morgan lens insertion or in foreign bodies and things, examination. And then if they have an irrigation, we put in the irrigation straight away. So once they've had their initial irrigation, by which time an hour has passed, and sometimes they're in a bit of pain when we take it out. So I'll reinstill a couple of drops then. Otherwise, after and post examination, but I've never come across somebody who wears off within 5 minutes, if I'm honest. So, but it can be given repeatedly. I believe actually up until the little pipette is empty. I've never had to use 2 pipettes, just the one, and either put 1 or 2 drops in until they've got effect. Sometimes it doesn't quite gain a good effect, and so I'll put another drop in just in case some has run down the face. I always warn them that it stings prior to insertion, because it does. I've had it put in when I had a foreign body in my eye. It really burns. It stings like hell. So just inform them of this and reassure them that this is normal. And like I said, oxybuprocaine, if you have it on PGD, can be used in children as it stings less. But tetracaine seems to be, I don't know what you all use. I think there was another one as well I found which tends to be used, but I've not, proparacaine. I'm not familiar with that, if I'm honest, so I can't tell you much on that. So testing the pH. So once we've given tetracaine, I go back and I look at my pH strip and what does it mean? So for those of you who aren't aware, pH of 7 to 7.5 is neutral, and tear fluid typically has a pH of 7.2 to 7.5. So that's normal for the eye. So any readings which on your pH color strip here, I'm not sure if you can see my arrow. So your pH testing, it's sometimes circular. You'll have 7, which is neutral. And anything higher than this indicates that your chemical is an alkali. So we tend to commonly see 9, 10s and 11s with alkali plaster in the eye. These colors look a little bit different, and they do tend to look different on different brand litmus paper. So don't get hung up on the colors much at all. You just want to make sure that your color of your litmus paper correlates with what's on the color strip. And anything lower, so these are acids down here. So I'm not sure if many of you remember this from physics in school, but yeah, your acidic is lower. Very, very seldom do I see an acid. I think hydrochloric acid is one of the ones that's in some of the household cleaners, and we sometimes see that, and that tends to be mildly acidic here around about the 5 and 6. Testing the pH, just to sum it up. So you should think now, testing the pH is a priority in any chemical injury to the eye. Triage, get them in, triage them, get a pH. And if your triage nurses or your healthcare assistants are deemed competent or able to gain a competency, I recommend training them and explaining the procedure, assessing their competency and allowing them to do it. Pretty sure we're all typically busy doing other things when these patients come in, so it really does help. And like I said, test the pH prior to your tetracaine. So for those of you that aren't practitioners or that are new to emergency care, may not know that alkaline is the most severe chemical eye injury, and probably, I think, the most common, given that we see a lot of workmen, occupational, coming in with wet plaster splashed in the eye, typically when they're skimming ceilings. Alkaline chemical injuries are absorbed more rapidly into the tissue. So remember that we talked about the anatomy of the cornea. This is the cornea here on the front of the eye. It doesn't look like a cornea, and that's because it's had an alkaline injury which has eaten away down to the stromal layer, and that's why you've got this stromal haze. This is not a good prognosis for this patient. Alkaline injuries can continue to damage the eye for hours post-injury, which is why it's important not to leave them sitting in the waiting room for 3 to 4 hours. You need to get them irrigated as quickly as possible. So even with irrigation, I'm not sure if any of you practitioners are aware, but even after irrigation, when the pH is normal, an alkali can continue to burn and eat through the epithelium of the cornea for hours afterwards. So, which is why we always tend to get them followed up with ICAS if possible. And explain the importance of irrigation to the patient. Some of them sometimes are a bit uncooperative or a bit uncompliant with irrigation, especially if it requires maybe 5-6 liters, which I've had to do in the past. And I just have to keep reassuring them that actually, if we don't get the pH normal, they could end up with a fisheye like this, and that it's sight threatening. So lime, lime is the most commonly found in building materials such as wet cement and plaster, as mentioned. And I've also found we see a lot of concentrated ammonia, which are in certain household cleaners. We get the odd patients coming in with those. Maybe they've been cleaning and they've mixed it up with water and something has splashed into their eye. Like I said, alkali chemicals, they can inflict severe injury within minutes. Sodium hydroxide, that's it, such as lye, can penetrate the anterior eye within 3 to 5 minutes and lead to irreversible blindness. Luckily, like I said, in the minor injuries unit, I don't think I've ever seen somebody with such a severe chemical eye injury, but I've seen 1 or 2 that I suspect look pretty bad the following day when they go to ICAS. So just remember that it can continue to burn even afterwards. Your acid substances then, so the acid substances are not as corrosive as the alkaline when it comes to the eye. Not a lot of people realize that, because you hear acid and you think, oh, it's acid, it's going to burn through, but alkali is actually worse. The acid though can cause coagulation, necrosis, which can result in, again, corneal ulceration and scarring. They do tend to be self-limited and tend to be found mostly concentrated acids. Once I've seen an acid attack patient, and that tends to cause more damage to some of the skin around the eye, as well as it can be quite corrosive and cause facial burns. So make sure that you're assessing for any signs of splashes around the eye, which we'll talk about on assessment. And commonly we do tend to see, so there's actually, as well as acid and alkaline, there's another subcategory of irritants. So yeah, irritants tend to consist of perfume, dilute shampoo, pepper spray. Yeah, perfume, dilute shampoo and pepper spray tend to be irritants as opposed to acid or alkali. So these substances may well show as a neutral pH when you test the pH, but they're still classed as chemicals. They typically still cause a burning sensation, stinging, redness, difficulty opening the eye, and can be very painful. So evidence suggests that if the patient is symptomatic, even if they've got a normal pH, we irrigate those. We may only need to give them a litre or so of normal saline, but still, it's still important to try and get rid of the chemical substance in the eye. Tox-base, and we'll talk a bit about tox-base again, but tox-base typically can advise you on whether or not a chemical is an alkali, an acid, or if it's an irritant. But I don't refer to tox-base until the patient has the irrigation going through. I think it's important to give the analgesia, commence irrigation, and then confirm exactly what the chemical is and how much fluid you should be irrigating, and you know what the advice is. I think it's important to note as well, so dry powder chemicals, so tear gas and dry powdered lime should not be irrigated with water. So if your patient has got dry powder, even though it's not a wet chemical, it's still a powdered chemical, but do not irrigate this. The water can react with the powder and has an exothermic reaction, thereby it pretty much just reacts in the eye. So that can make the chemical injury much worse than what it probably already is. So evidence suggests it's best to remove any matter from around the eye and the inner eyelid with a cotton bud, just to sweep the lower eyelid of any powdered matter. And also, if they still feel like something is in the eye, it's best to get a fan in a well-ventilated room and blow the fan across the eyes to try and get rid of the powder. But I don't think in my practice I've ever seen that, if I'm honest. It always tends to be a wet plaster or a bleach or some form of household. Here are some examples, actually. I think I've put a table on this slide, yeah. So here are your typical examples. I've pulled this off of a great website called Up to Date. If any of you ever heard of that, or if you haven't used it, it's really good. Normally, I think a lot of the trusts have got trust access through Open Affins. So if you aren't using it, it's really good for up-to-date information. Although some of it is based as American, but some of this information is interesting with regards to treatment and management. So yeah, and this is quite worrying. So I didn't realize that your typical toilet bowl cleaner, I suppose, yeah, has got acid in it. We tend to see that sometimes as well. People are sort of cleaning, let's say bleach cleaning and wet plaster tend to be your most common. So irrigation, once you've ascertained that they've got a chemical, you've given them tetracaine after testing the pH, and you've ascertained if it's an acid or an alkali, either way you're going to irrigate. So the irrigation, I'm sure a lot of you have possibly seen it in the ED or done it as nursing practitioners, is irrigation is best practice, commonly given through a standard giving set with a normal saline bag or Hartmann's bag connected to the giving set and run through a bit like an IV, except instead of the IV line and Venflon connected to the Venflon on the end of it, you've got a Morgan lens. That tends to be worldwide, I think it's used worldwide, and it is best recommended practice. If you've got them in the department, give it through a Morgan lens. They are designed to irrigate the eye comfortably and flush the cornea, flush the inside of the eye, and get rid of any foreign body and matter. Like I said, commencing copious irrigation is crucial to reducing the severity of the burn. Don't waste any time. Get that irrigation going. We tend to use normal saline in our department, but Hartmann's or Ringer's lactate is commonly used. And I think it was the Morgan Lens Company that did a study, and the Morgan Lens Company study determined and concluded that Ringer's lactate has a pH that is more closer to the tear film and is possibly more effective in irrigation, but normal saline tends to be what we use. I'm not sure if you have to have a PGD for that. I could do with finding that out actually. If there's a PGD for irrigation, we don't tend to document it as a medication or a fluid on a fluid chart as we would give it intravenously, but I do write it on the cash card and also on my eye performer or my documentation of the eye assessment that I've commenced irrigation with 1 litre of normal saline via a Morgan's lens. Interestingly, the Morgan lens packaging has a quick reference on it as well. So not many people know that, but it pretty much is a minimum. So alkaline burns minimum of 2 litres, acid burns minimum of 1 litre. But like I say, I tend to check with ToxBase more specifically for what the chemical is and the recommended irrigation. Don't delay irrigation to check ToxBase though. Just start the irrigation. And actually, yeah, so if none of you have seen it, I think I saved the video as well here, but we'll talk about that. Asking Sandra, 15 to 20 minutes, yeah, post irrigation, we advise taking the Morgan lens once it's finished, take the Morgan lens out, leave the patient for 15 to 20 minutes, and then check your pH to compare it to your baseline pH. If it's still abnormal, you must continue irrigation. The local eye casualty to us will not accept a patient until normal pH has been achieved. So when we were talking about the normal pH, if your pH is 7.5, if it's 8, they are quite strict and they will not accept the patient until irrigation has resulted in a normal pH between 7 and 7.5. Which is a bit frustrating sometimes because we have patients who have only got one eye affected and the opposite eye possibly may well be the same, 7.5 or 8. And so I tend to document then that the pH is the same in both eyes and the opposite eye is not symptomatic. So if you are discharging a patient discharging a patient with an abnormal pH and it's somewhere along the lines of 7.5 to 8, make sure that that is because it correlates with the opposite eye and that there are no symptoms in the opposite eye. Because eye cash will have a dicky fit. I think the most, so I've had to continue irrigation for 6 to 7 litres. I think I had to put through one patient because he had such a severe alkali. And at 7 litres, I then had to refer him to A&E because the department was closing and we were referring him to continue irrigation. If that's necessary, then you have to do it. The patient wasn't very happy, but unfortunately with a pH of 9, I think it was, even after 6, 7 litres, he was still under a big risk of sustaining corneal damage and deteriorating if we sent him home with that. Between irrigation, so if the patient allows initially, but not always, I think the triage nurse and the HCAs don't tend to invert the eyelid in our department. But if I'm seeing and treating the patient and I'm suspicious that there could be some clumps of wet plaster, for example, in the eyelids or underneath, then I do a quick fornix sweep with a cotton bud to check. Otherwise, I tend to do it after initial irrigation and just to have a little look because it can be dislodged with the Morgan lens and then get a little bit trapped under the lower eyelid. So just make sure that if you've got a nursing practitioner, or if you're able to, if you're suspicious that something may still be in the eye of the complainant, that they feel like there's a grittiness or something under their eyelid, have a little look. No point in irrigating it if there's something still in there. Children, so children not very compliant when it comes to inserting Morgan lenses. I don't think I've ever had to do it. Once there was I think a young child who was relatively compliant, in all fairness to her, but other than that, they normally don't tolerate it. So what I tend to do is get mum to hold them over the sink, or cradle them in their arms, and just run the litre of saline through your standard given set, and just allow the fluid to flow out of the end. And as cruel as it seems, try and hold the eyelids open and really irrigate it into the eye to get it out. Luckily, we don't tend to see many nasty chemical eye injuries in children. They seem to be irritants. So irrigation is mainly symptomatic to relieve symptoms. And actually, if they're mildly uncomfortable and the child is just irritated by the eye as opposed to in severe pain, if the pH is normal, after instilling tetracaine, I may well just instill the fluorescein and see and treat the patient if they're a child, and just advise mum to copiously irrigate at home in the bath or something, if there's no fluorescein staining, but that's all patient dependent. So when it comes to irrigation with the Morgan lens is best practice. We've talked about the kit needed, 1 litre of saline, standard given set, and your Morgan lens. Typically 2 litres for your alkali burns. And while that initial irrigation is going through, check top space, but always refer to your pH. So once the initial irrigation has gone through, wait 20 minutes, check your pH and compare with your baseline. If you're still alkali or if it's still acidic, continue to irrigate with another litre or another 2 litres. The top space advice does tend to say continue irrigation until pH normal. I like to refer to top space to check if eye exposure from a certain chemical is an irritant, more so, because it will, under eye exposure, it will say this is an irritant. So I know that I'm not hugely concerned if the pH is relatively normal and the patient has some mild pain, then obviously you won't need to irrigate further, but your pH is going to show relatively normal in comparison with the other eye. It's not going to look anything like this. Few points to make, really. So I just note before the irrigation, don't delay irrigation to test the visual acuity either. So not necessary in chemical eye injuries. You just want to get that irrigation, pain relief and irrigation. Visual acuity can be checked afterwards, because all the while that you are waiting and assessing or checking the visual acuity, that chemical could be eaten away at the cornea and you're just going to risk causing more damage. So don't delay it. Certainly don't perform a full assessment prior to inserting the Morgan lens and starting irrigation. And as said, baseline pH, if it's neutral, still commence irrigation if the patient is symptomatic. You may only want to use 1 litre and then check the pH, see if they're feeling a bit better from the symptoms, and ensure topical analgesia given. So we've covered that more than once. Some contraindications for Morgan lens. So you don't want to be putting your Morgan lens in if there is a suspected globe rupture. You certainly don't want to be putting it in if there's a protruding foreign body or a penetrating eye injury. So these sort of injuries here, along with a chemical eye injury, your patient is probably going to be more in majors, maybe even recessed from a trauma. And hopefully everything will have been assessed prior to the insertion of Morgan lens, so that they may, just in case they're at risk of having a severe head injury or penetrating eye injuries and suspected globe ruptures, if they're in severe pain from a chemical injury, I read that you can just start gentle irrigation to try and relieve symptoms. They've probably got some other significant injuries going on that take priority. For those of you that don't know how, and I think there's a couple of staff nurses here tonight or that may be watching on catch up, nobody ever showed me how to insert a Morgan lens, and it was only when I was training as an ENP that I actually got competently assessed with a DOPS. Never had that as an emergency nurse, and the instructions are on the back of the packaging, but I thought here's a little quick demonstration for you. For those of you who haven't seen it or new to it.
90% of the emergency departments in the United States.
You can see and hear this. No. Move it across to there. Can you see that, guys? Somebody tell me.
No, no,
Oh,
no.
what can you see? Can you see my
Just still the slide.
hang on then.
For 90% of the emergency departments in the United States.
Can you see that?
No.
No. Okay.
Yes, now we can. Yeah.
Ta-da!
Yeah.
Oh, I'll be a pro by the end of this now. This is all new to me, sharing screens and all sorts. So, okay, let's not delay. It's only a couple of minutes or a few minutes, but
Injuries to the eye, they're different. So when a patient comes in with multiple injuries plus ocular trauma, alkali burns, acid burns, foreign bodies, visible or not, the eyes can't wait. The Morgan lens provides a fast, bilateral, hands-free method for emergency eye irrigation, one that gently irrigates or delivers a controlled dose of antibiotics to the cornea and conjunctiva. Immediate treatment of the eye calms the patient and makes it easier to work on other injuries. Transporting your patient to or throughout the hospital is possible without having to stop the irrigation process. Just like over 90% of the emergency departments in the United States, you should be using the Morgan lens. Once inserted, the Morgan lens floats on the very layer of solution it provides. Designed to fit the natural curvature of the eye, the lens protects the tender ocular tissues and vaults the cornea, never touching it. As the lens floats above the eye, preventing further damage from eyelid movement, the flushing process soothes the eye and provides instant relief to the injured tissues. When treating severe infections, doctors have used the Morgan lens for continuous eye irrigation for 7 to 10 days or more, removing them only long enough to examine the eyes. The Morgan lens is simple to use. First, if one is available and the patient has no allergies, instill a topical ocular anesthetic. This isn't essential, but it may help calm the patient. However, when removing non-embedded foreign bodies, it may be best not to use an anesthetic since it could mask the foreign body sensation. Peel open the sterile packaging and attach the Morgan lens to the Morgan lens delivery set and solution of choice. The delivery set allows you to easily irrigate both eyes simultaneously, or just one eye using the pinch clamp. You may also use a standard IV set or attach a syringe if you need a smaller, more controlled application. Begin a minimal flow. To insert the lens, have your patient look down. This exposes the less sensitive sclera and protects the cornea. Insert the lens under the upper eyelid. Have the patient look up, retract the lower lid, and drop the lens in place. Adjust the flow to the desired rate and absorb the outflow with Mortan's Metaduct or towels. The Metaduct conveniently wicks the fluid away from the patient and into a basin or other collection device. To prevent the accidental removal of the lens, the tubing may be taped to the patient's forehead as shown. Experts recommend continuous irrigation until the pH returns to normal. This may take hours or even days. To check the pH or to instill additional anesthetic, you don't need to remove the lens. Simply pinch the tubing to briefly stop the flow of solution and touch a piece of pH paper to the conjunctival fornix. Removal is just as easy. With the solution still flowing, instruct the patient to look up, retract the lower lid, and slide the lens out. Once the lens has been removed, stop the flow of solution and place the lens in a clean location. Recheck the pH after 10 minutes to ensure that it's remained neutral, and repeat the irrigation process if necessary. When finished, dispose of the lens properly. Again, to insert, have the patient look down and insert the Morgan lens under the upper eyelid. Have the patient look up, retract the lower lid, and drop lens in place. To remove, continue the flow of solution. Have your patient look up, retract lower lid, and slide the Morgan lens out. Once the lens is removed, terminate the flow. No other method of eye irrigation is as simple or as effective. Consider the alternatives for a moment. Traditional methods of eye treatment are inefficient and ineffective, but the Morgan lens is so easy to use. Non-embedded foreign bodies, even the kind that can't be seen, are removed effectively and thoroughly. The Morgan lens is the only device to provide a positive and multi-directional flow throughout the cul-de-sac, keeping the cornea, conjunctiva, and normally untreated inner eyelids thoroughly flushed. Experts have said that regardless of the chemical involved, immediate and copious irrigation is most important. Contraindications include a protruding foreign body, a penetrating eye injury, or suspected or actual rupture of the globe. In all other cases, begin immediate irrigation and wait to perform a more detailed evaluation or history until treatment is underway. Join over 90% of the country's emergency departments and make the Morgan lens your first line of defense against ocular.
Okay, so I'm going to pause it there because I'm pretty sure what I've done here. Oh, there we are. Yeah, no. So do you mean to insert it, Sandra? Sorry.
No. I mean, what I tend to do is invert the eyelid to make sure that that's had a proper washout. With the Morgan lens, what I didn't realise is that it actually does that anyway, doesn't it?
Yeah.
You probably don't need to separately invert the eyelid.
Oh yeah, no, sorry, yeah. So and that's why I quite like that video, because it demonstrates how it sits on the eye and flushes into the eye and then out through the only difference is we don't often have the luxury of laying our patients down on the trolley like they did in the video.
No, over the sink.
They're hanging over the sink with a towel wrapped around them, yeah. But I expect they're probably designed to be used like that, laying down and as you saw, so they had them in both eyes, but yeah, one eye. Something else I noticed on the video as well that I didn't realize that was a good point to note, and that is to make sure that you actually flow the fluid into the Morgan lens. So I haven't included that on the presentation, but I always make sure that when I start the irrigation, I run the fluid through the standard given set and holding the Morgan lens in my one hand, and I open the flow to ensure that there is fluid on the surface of the Morgan lens to lubricate it and wet it before inserting it into the patient's eye. But yeah, that's the beauty of the Morgan lens. You can pretty much just get it in and
leave them do it. Yeah.
Yeah, they're used worldwide. I didn't know that they're the standard irrigation in America and everywhere. So yeah, any questions on the Morgan lenses? No, feel free to message me afterwards anyway if you have any questions. I'm going to press on because I'm aware that we're due to technical glitch, we're running a little bit behind. So if anybody needs to leave, then apologies for the technical glitch, and just feel free to leave whenever you need to. All right, I'm going to talk at the moment now. So I'm going to talk about the assessing practitioners side of things. So what I would do as an ENP as opposed to triage, and just to sum it up really, actually, the healthcare assistants in our department can do the majority of what I've just discussed. So they can test the pH and they can also insert the Morgan lens and start the irrigation. So check with your local department if that's possible. If they haven't had training or if they're not deemed competent, find out if they want to and assess them as, teach them and assess them as competent if you're able to, or if you want to. They, some departments don't allow HCAs to do that, so just be careful. We have a competency file for each of ours. and they can carry on and get that done straight from triage. So the patient pretty much has their irrigation going when I go in to take some details, and once they finish their irrigation, that's when I start my assessment. So I'm not going to repeat a lot of this because this is what we talked about in triage. So you're presenting complete, being your chemical injury, history, symptoms. So some of the other symptoms that maybe we may well want to ask the patient is, have they had any halos or floaters or flashing lights, or any certain significant symptoms as such? Typically they present with pain, blurred vision, eye watering, and that tends to be it. The pain, blurred vision and eye watering. If the triage nurse hasn't documented, then make sure you're documenting their past medical history, drug history and ocular history. As I said earlier, so these are important because they can actually complicate your assessment when you come to look at the cornea and the deeper structures of the eye. So for instance, cataracts are a nightmare. Patient who has had a chemical burn with a cataract or glaucoma, and they've already got that corneal haze. How do you tell what's cataract and what's corneal burn? Very difficult. So make sure you are certain if they've got cataracts, previous ocular surgery, which may have resulted in corneal scarring or an opaque cornea. If they've already, or if they're known to have that opaque cornea, then that's important to know. They may well say, yeah, it's normally like that. And you've been worrying about a severe injury. But I tend to check all of this, like I said, after irrigation. Even if the triage nurse has already documented a good triage, best practice, I personally prefer to recheck all the details of the chemical incident and their past medical history, just to make sure I don't miss anything. I double check their allergies and tetanus. So I don't always see tetanus, but when I trained as an ENP, writing up my case studies, I learned that tetanus is very important, especially if you have a corneal abrasion, because it's classed as a wound and there is still a risk of tetanus entering through the wound in the eye, and the patient can end up, it's very low rate, I'm not sure of the numbers, but it's classed as it is a wound, and it can penetrate, and the patient can get tetanus from that, from the corneal abrasion, which you do typically see in chemical injuries. It tends to be the most common outcome that I've seen, and that is that the patient has that epithelial damage from the chemical, and they've got that haziness or a lot of uptake on fluorescein. Once I finish, so go through the quick sort of history and the past medical history, make sure I've got all those necessary things, and then I proceed with visual acuity. So if you're not familiar with the visual acuity, typical Snellen chart tends to be used here. Again, our triage nurses are assessed as competent to test vision and visual acuity, which is useful with foreign bodies and other problems. But like I said, don't worry about testing visual acuity if they're a chemical injury until after they've had their irrigation. Other charts that are used, you may well see this in the department, that's your Tumbling E-Chart. A lot of people don't actually know what it's used for or how you would read it, but this is called the Tumbling E, and this is for illiterate or possibly mute people who may just find it easier to indicate which direction they're seeing the E in. I've never had to use it personally, but it's good to know what it's for. Picture charts, I love picture charts for children. Children are not easy to do visual acuity, so I tend to play game with them and say, can you see the pictures up on the wall? Can you name them? And they seem to enjoy that. The Snellen chart is typically designed for 6 meters, though we don't have 6 meters in our assessing areas. We typically use them at 3 meters, and typically you would stand the patient at 3 meters, you get them to occlude one eye and read down the Snellen chart from top to bottom. You've all done that in the eye test, I'm pretty sure. But then you would document, so common error that I see is not documented properly, as a fraction. So the top number is the distance that you're reading it at, e.g. you'll see 636. If the patient is able to read line 36, which I believe is this one, AOX here. So if they can see that clearly, you and nothing underneath clearly, you would document that as 6/36. A pinhole as well. So actually a pinhole, not many people know how to use the pinhole or what it's used for. This actually corrects any refractive error. So if the visual acuity is less than 6/9, and obviously I don't think I've mentioned the patient ideally should be wearing their glasses at this point if they have them. Obviously, if they normally wear glasses and they haven't got them on and they can't see that, that's why. If you use the pinhole, you get them to, it occludes the one eye and you get them to focus through one of these little pinholes, and it should correct any refractive error. And quite often the patient can see a lot better or a lot clearer than what they could. So they may well be able to see a few extra lines down a bit clearer. I tend to tell the patient just to read down as far as they can see clearly. So if it starts to get a bit blurry and they look like they're guessing it, I would just document it as the line above. You can be specific. There are some rules with regards to what they can see, what numbers or how many from one line or the other, but I don't document that. I've never really seen it documented as evidence-based in any of my books either, so I can't comment on it. One of our triage nurses does it though. If the patient has altered or decreased visual acuity, this is how you would document. So if they're unable to read the top line of the Snellen picture chart because their visual acuity is that bad, even with the pinhole, they're not able to, then you just ask them to reduce the distance to 1 meter. You get them standing at 1 meter from the letters. And if they can see that, you would document it as 1 meter instead of 6, sorry. So I probably should note that even though it's 6 meters and we reduce that typically in the department to 3 meters, the charts are reduced by 50% in size. So even though it's 3 meters, we still document it as a fraction with 6 because the picture chart or the Snellen chart is adjusted also. So we don't document it as 3/36. If the patient isn't able, even at 1 meter, to read the Snellen chart, if they're really struggling to see, then you would ask them to recognize any letters at all. And if they can't, I would typically ask them to count fingers, and it's best practice to follow this method of seeing if they can count fingers. And if so, record your distance and CF for count fingers. If the patient can't count fingers, ask them to, if they can detect hand movement, and you would document that as HM at 1 meter, or possibly they might be able to detect waving hand at 3 meters. If they're unable to detect a hand movement, then this is not a good prognosis. And if it's not normal for the patient, then you should probably be a bit concerned. Use a pen torch, ask if they can perceive the light, and determine from, you know, any light at all or any shapes at all. Try and just do anything that they can see. If they can't detect the light of a pen torch and all they can see is a darkness, then the patient has no perception of light. And if the patient has nil perception of light, you probably want to get on the phone to ophthalmology. Have a good assessment of their eye and what's going on quite briefly, but it's not a good sign if they can't perceive light. That's quite severe injury. Examination then, so visual acuity, I've got a structured approach to this really now, and as an examiner you'll probably find the same. I once I've irrigated, I sit them on the chair, or I get them to do the Snellen chart rather. Then I sit them on the chair or on the couch, and I'll start with the pupils. So you want to check obviously their size, shape and symmetry of the pupils, and that document that they react. And consensual light reflexes. So that's when you, if you're not aware, you shine the pen torch into the right eye, for instance, and you watch the reflex in the left eye. And then you swap over and you shine the torch in the left eye, and you ensure that the right eye is reacting. And that tells the, it's basically confirming that the optic nerve and the brain and the components of the eye are all working simultaneously, a bit like your tendon reflexes when you're testing reflexes in neck and back injuries, for instance. Eye movement, so I proceed then, the things that I can do while the patient is sitting comfortably. I test the range of movement of the eye. So as we mentioned earlier, there are 6 muscles, and from arm's length, if you draw a H pattern with a pen torch, asking them to follow with their eyes and keep their head still, then the patient quite often will follow up, down, left, right, and across the center. And you really want to make sure at this point, so double vision is not very common in chemical eye injuries, but pain. So I tend to document if the patient has any pain on range of movement of their eyes, or if they have any sort of sticking, or normally they don't, if I'm honest. I typically don't come across patients with problems with range of movement, only that it can feel a bit achy, maybe where they've had the Morgan lens in, or from the burns itself. So yeah, so then I move on a bit more sort of closer to the eye itself, and I have a closer look at the external eye. So you want to be documenting if they've got any signs of facial burns or trauma surrounding the eye, noting if the eyelids are swollen or any erythema, any blistering, a bit like you would a typical skin burn. Make sure when you're documenting examination of the eye that you're including the eye socket, the lids and the eyelashes to look. And Sandra, like you said, everting. So I do evert, but after irrigation, I evert the eyelid to look for any signs of burns or avascular areas underneath. Typically, the conjunctiva tends to be just red and aggravated looking. Anatomy, so this is where the anatomy comes in handy. The conjunctiva quite often will look injected and quite aggravated in chemical burns. I tend to note what I've got here: hemorrhage, post margins visible. Don't typically present in chemical eye injuries. It tends to be the swelling or chemosis, which is edema of the sclera, and bulging, and injection of the eye. But it's good to note that those are some of the things that you look for in an eye assessment. The iris, so in severe burns, such as here on this page, this is quite a significant chemical eye burn. And so here you can see that the cornea is very hazy, stromal haze, this is called, and opaque. The sclera of the eye here is white, and this is what we call scleral ischemia. So this is basically severe damage to the blood vessels sitting between the sclera and the conjunctival membrane. And this indicates ischemia of that area, and limbal ischemia, which is this circular area here. This is not good. So this is quite a significant chemical burn. If after irrigation you're looking at this, this is quite a poor prognosis, and definitely warrants ophthalmology referral. So the limbus, like I said, quite often it is circulated around here. It looks quite clear normally, and typically it doesn't look like there's any abnormality to it. The anterior chamber is here in the hypopyon area. think there's hypopyon. Yeah, so here, this is a small example of a hypopyon pus in the anterior chamber, which can form with significant inflammation, secondary to ocular chemical burns. Blood you don't tend to see in the anterior chamber unless it's trauma, but I did note that pus from inflammation and infection from chemical burn can be seen. Typically the cornea, the conjunctiva, the iris, the limbus and the cornea tend to be what's affected in a chemical eye injury, and it tends to be the cornea that you want to detect with the fluorescein more so. So my concern, or my priority after irrigation, as well as performing all those examination of the eye, is to instill fluorescein so that I can detect any epithelial damage, because typically under the from the naked eye, I should say, the surface of the eye tends to look pretty normal. You may not see any of these horrific severe chemical eye injuries, especially on initial presentations. You may only just see the redness and the pain, a slight bit of haziness to the cornea. And so after you've done that, you want to proceed with fluorescein installation. And if you've never seen it or done it, it's fascinating. And fluorescein is pretty much a dye which sits in the epithelial abrasions within the cornea and show up under a cobalt blue light. So you need to have the cobalt blue light, whether it's on the ophthalmoscope or the slit lamp. If you're not competent in or familiar with using the slit lamp and you're an assessing practitioner, I certainly recommend checking out Tim Root's website. He's a eye professor based in America, but he is a very, he explains things very well. He does some really good videos, and he's got a really good video on slit lamp exam tutorial, which I used. Again, I was never, up until becoming a trainee, I was never really familiar. And even some of the senior EMPs in the department didn't used to use the slit lamp very often. So, but I love it. I've familiarized myself with it now, and the different layers of the slit lamp can really allow a magnified visualization and a real accurate assessment of the eye structures. Not typically necessary in a chemical eye injury initially, because short of instilling fluorescein and looking for the extent of any corneal damage, the eye casualty will follow them up and assess the depth of the burn. I have read that you can actually detect how deep the burn is, whether it's gone through the epithelial, if it's down to the stromal, but it's very difficult, in my personal opinion, to assess that. But this video on knowing your way around the slit lamp and using it for magnified looking at the eye and what the different layers are used for is really good. Yeah, fluorescein 1% tends to be what's used. Like I said, just concentrates here like this. So this is a corneal defect following a chemical injury. It's also what we call a corneal abrasion, if you've ever heard of that. So corneal abrasion is a injury to that cornea. It takes off the epithelial layer, sometimes a bit deeper, but typically it is the top layers. You can sometimes see the depth if you're looking really closely, especially through the slit lamp, but I wouldn't be able to say what layers they are. But yeah, definitely very interesting if you're not familiar with using it. So once you've actually instilled your fluorescein and you have examined the external eye, you can pretty much judge what sort of how to grade this. So you should know, is it well, I don't personally know the grades off by heart, but I know that if it's a mild injury, then you're just going to have some isolated corneal defects like we saw in the previous picture. No limbal ischemia. Typically it's all very red and aggravated, and that's a good sign. If it's white, it's limbal ischemia, is not good. Grade 2 can be classed as quite minor as well, I've seen patients that have got a slight haze in the cornea, but you can still see the pupil and the coloured part of the iris quite clearly. And these do have good prognosis as well. When we get, this is the Roper Hall, when we get down to the grade 3 in Roper Hall, there tends to be more of a complete epithelial loss. You'll have a complete haziness across the corner of the eye, and you will not be able to clearly see the iris, the coloured part of the eye. Grade 5, needless to say, very poor prognosis, as you can see here. So this is a really opaque iris with nothing visible. It's what we call a fisheye. It's not nice at all, and very poor prognosis. These typically require urgent referral to the ophthalmology that day. With regards to referring, actually, some chloramphenicol first. So even though I tend to go on what I'm advised by the ICAJ. I don't give them chloramphenicol until I've spoken with ICAJ, but I do treat mild and minor grade 1 and grade 2 with chloramphenicol, and if it's very minor with a very small uptake of fluorescein, and then I will advise them to use the chloramphenicol a few times a day. But if they're more severe, then evidence says that you can apply as often as 2 hourly for symptomatic relief. So typically in the BNF, for instance, chloramphenicol is I think 3-4 times a day, but in some of the evidence in chemical eye injuries, I found then even 1 to 2 hourly can cause the patient to have some good comfort and analgesia. It provides lubrication. I didn't realize that the reason why we want to provide lubrication is the Morgan lens irrigates the natural tear film away. And so quite often that's why patients will feel a gritty sensation in conjunctivitis and have to eye irrigation, is because the tear film, which lubricates the conjunctiva and the surface of the eye, has gone, and what they're feeling is that real red inflamed of the eyelid over the eye. So evidence says comfort and analgesia and lubrication, but most importantly, the evidence base suggests that it is mainly to prevent risk of infection and ulceration from developing. So the cornea, if there is any corneal damage or any corneal defect, evidence suggests giving chloramphenicol to reduce any risk of infection and provide comfort and prevent any ulceration. If you've never seen a corneal ulcer, have a look on Google Images. They catch you every now and then when the patient says they feel a foreign body in the eye, but there's no clear history of a foreign body. You can't see a foreign body, but they have a nice tiny little uptake. I always suspect an ulceration in that case, and they can be very painful and require referral to ophthalmology as well. The chloramphenicol, you best check on PGD if you don't prescribe. Our PGD says that we can only give it for the treatment of infections. So I tend to document that ICAJ have recommended it, even though I've also seen in evidence-based articles when I was training as an ENP that it is very beneficial and comforting for the patient as an analgesia and lubricant, as well as protecting from risk of infection, Our PGD says that we are not allowed to give it to breastfeeding mothers, and that we should be cautious in bone marrow hyperplasia patients. And interestingly, an analogy to liquid paraffin, which makes sense because it is very much, especially chloramphenicol ointment, is paraffin based, and I never thought about that. But yeah, any sensitivity or allergy to liquid paraffin, be very aware. Chemical injuries from irritants such as perfume, dilute shampoo, or pepper spray, like I mentioned earlier, typically don't always have any uptake with fluorescein, and short of having some pain and injected conjunctiva, they're quite self-limiting. I don't tend to, well, I don't give patients any chlorphenicol for these injuries. Instead, I advise them to just purchase some lubricating drops if they like over the counter. And these patients are safe to be discharged with, as long as they've got normal pH, and it's definitely an irritant, with advice to see an optician SOS. So that's seen on symptoms. So if they continue to have any symptoms or problems, direct them to the community optician. I think so. Actually, ICAJ always advise us to give chlorphenicol to the chemical injuries, no matter whether it's alkali or acid. I quite often do go on what advice they give. I don't know about your local policies and procedures where you are in the UK, but in our unit, we don't have appointments which we automatically give for ICAJ. We ring through and we make appointments. And I pretty much do this with all my patients based on the individual case. So even if there's an alkali or acid injury and they don't have any fluorescein, or on examination, everything seems quite normal other than pain and a bit of blurred vision, I still ring ICAJ, because my discharge advice and my aftercare and follow-up, I like to make sure that that's based on what ICAJ always advise. So the grade 1 and 2 injuries that we talked about, evidence says that sometimes they don't need to have follow-up, but personally, I think it's recommended in good practice to discuss them all, or if you can't discuss, give them an appointment, because like I said, corneal burns can carry on burning, any chemical injury, can carry on burning for hours afterwards. And so what you're looking at that day may not look like that in 24, 48 hours. A bit like a normal skin burn. It may look erythema or just red and mildly blistered. 2 days down the line, it might look quite significantly worse. And these are eyes. So yeah, don't mess with them. I always discuss with local ICAJ for guidance on follow-up. The reasoning for, if anybody has any corneal defect, even if it's quite small, so I've heard 1 or 2 of the ENPs previous in practice, if it's a very small abrasion or a very small amount of uptake, they don't need to be followed up, they don't need any chlorphenicol. From my practice and what I learned when I was training, the main reason you want to be giving them follow-up and chlorphenicol is because of the increased risk of sight-threatening infection from the corneal defect. So anything Pseudomonas can get in there, and they can get real nasty infections. And the fact that the ICAJ may need to review the depth of the burn and monitor healing, especially if it's an alkali. Like I said, alkali's nasty. And if no corneal defect, if they're not symptomatic, no corneal defect, ICAJ have said follow up with optician in a week. I don't tend to make that decision on my own at the moment. I would pretty much get the advice from ICAJ so that I can document that that is what they've instructed to do. Other than grade 1 and 2, grade 3s and 4s, you want to be referring all of these urgently. If it's out of hours, I would ring and speak to your ophthalmology on call, because they typically require admission, not only for analgesia, but continued irrigation. Chemical burns, even if they don't look hugely significant or severe, they can actually get a lot of inflammation, and this can increase the intraocular pressure, which I didn't realize, and that can also need treatment and to reduce this, and monitoring on the eye clinic ward, eye casualty ward, I should say. And actually some treatments that they tend to do on a regular basis, I'm told, is debride the necrotic areas of epithelium to promote reepithelialization, like we do with skin burns, which is quite interesting. Long-term management. So these patients are going to need some long-term management of their chemical burns. So be sure to to refer all of these. And like I said, discuss 1 and 2 quite often, unless I'm 100% sure that this patient is not very symptomatic, it's not an alkali, its pH is neutral, and then quite often maybe I'll just say to them, use the chlorphenicol and optician to follow up in a few days. You may well have local, already local procedures in place for this. If these patients are going to be going to eye clinic or eye casualty, as it's called, I tend to instill chlorphenicol. Quite often they're quite nasty looking burns, and you want to be putting some chlorphenicol in for comfort and patch the eye. It's not routinely used, but yeah, it's not routinely advised to patch the eye to discharge them, but it can just ensure a bit of comfort and keep it nice and moist. Lastly, any patient that you're discharging, there's not an awful lot more information you can give them other than to ensure that they fully understand the process and offer them reassurance that, you know, the importance of following up with iCash so that they don't skip their appointment, or, you know, if they're worried about their sight and losing any vision and things, just try and communicate everything to them and reassure them. I think that's about it. I don't think, other than discharge advice, really. Do not ever give tetracaine on discharge. So just yesterday I was discussing with one of our trainees, and in one of her case reviews, when we were talking about chemical injuries, she actually saw a patient who was discharged or sent home from where he attended with tetracaine as a take home. So this tetracaine can be instilled, it can be repeatedly instilled for analgesia. Do not give it to the patient to go home. Long-term use of tetracaine or repetitive use over sort of 24 hours can actually cause more damage to the surface of the cornea, to the epithelium. So it's only for use in hospital. Sometimes I do give them drops before they go, if it's still feeling a bit painful, if they're not going to iCash until the following day for review. I'll give them a couple of drops before they go, just to give them that little bit of relief, and discharge them. If they've got their eye patch, be careful not to send them in the car and let them drive. Make sure they've got somebody to take them. As silly as that may sound, believe it or not, we've had people sent to us with injuries that they should not be driving with. I think that's about it anyway. So I know we've run over a bit and we were going through some technical glitches, so I'm really sorry I've kept you all. Any questions? Are you all still awake? Are you all still alive?
Yes.
Oh, right, so references, no, that's fine, don't need to see those. Yeah, thanks for listening. Thank you all for joining me tonight, and hope you've enjoyed it. I hope you've all learned something anyway, even if it was a bit of a death by PowerPoint situation.
Thank you, brilliant.
Thanks, Suze. Cheers. Thank you very much.
Any
That's okay.
questions?